A 20-year-old male student who had presented with drooping of his left eye and deviation of eyes. About which eye is deviating, he was not sure. This complaint was there from childhood, for which no treatment was taken so far. This is the patient. Very obviously, the left eye is ptotic and is hypotropic. And suddenly you see that the left eye is normal, taking a fixation, there is no ptosis, but instead his right eye is deviated upwards. This is what has happened. So when he is fixing with his right eye, the left eye appears to be looking down. Suddenly when you fix with the left eye, this has happened. Left eye is continuing to fix and the right eye has gone up. That is why he was not sure as to what his presenting complaint is, which eye is deviating when. Versions were almost okay except for a minimal limitation in the abduction in the right eye, in the left eye. The downwards gaze was full, but the upward gaze was restricted in the left eye. But obviously, the left eye has a limitation of elevation and it is esotropic. This is how when he looks down in the left eye, the palpebral fissure is a little widened in the left side. At times, it is more retracted and at times is absolutely normal. This is the ptotic left eye and suddenly he can fix with that eye and it's continuing to fix even without a jaw winking. It's retracted but not beyond the limbus and he's fixing with this left eye. This we are testing a jaw winking and a true synchronous is not so obvious. You can see that it is little getting retracted but not beyond the limbus. Because he is using his right eye more, his vision was preserved in the right eye, and the left eye, because it is hypertropic and the significant ptosis, had made it moderately amblyopic. Measurement shows a significant hypertropia with an ESO in the left eye, and showing that it is an incommitant deviation. When the left eye takes a fixation, the same innervation is being given to superior rectus, which is actually putting the right eye to a more upward position. We have seen there is a pseudoptosis and elevation restricted, and force duction test was positive for inferior rectus and medial rectus, showing that there is some contracture, maybe because of the long-standing ailment. Otherwise, the examination was within normal limits. But the problem was that the patient and the parents were confused as to what his symptoms are. Because of the intermittency of the deviation and the variation in presentation, they were not sure what exactly they want. He very badly want to pursue his studies in hotel management, where a public appearance and a direct eye-to-eye contact was very much needed, and so he was really confused and depressed as to whether it is possible or not. And not only that, he was taken to different consultants. In the younger age group, when he had a ptosis prominent, he was advised ptosis surgery, which was said to correct the problem. Later, when the right eye became hypertropic, he was advised right eye surgery was better. And at times when both eyes was problematic, that was also recommended. And so they were not sure whether this treatment, because of the difference, whether it's going to correct his problem. So far in the school year, he was continuing with that, and along with the fear of GA and the surgery for both himself and his parents, prolonged the treatment. So they were not confused whether to take up the treatment or not. So with the diagnosis of an incommitant hypotropia and esotropia with a pseudoptosis in the left eye, with a differential diagnosis of a double elevator palsy because the elevation was restricted, we had a plan recommended to him. I had explained that his left eye was low, so we have to do an inferior rectus recession to make that eye central or high up. And to improve the elevation of the left eye, we'll have to transpose the medial rectus and the lateral rectus. After the medial rectus is recessed, both these horizontal muscles has to be taken up and fixed close to the superior rectus of the left eye to improve the elevation. And after having done with the left eye, if he is found to have a prominent hypertropia in the right eye has to be pulled down. Then if the ptosis is prominent, we'll have to tackle the ptosis, and if the jaw winging is prominent, we'll have to do surgery as levator recession or disinsertion in both the eyes, and then pull up both the lids with a frontalis sling bilaterally. This is such an elaborate plan I had discussed. I think they got even more confused and they told that not willing to take it at this instant and then left. They came back after 6 months thinking that they'll take a chance, and by that time I became more stable and I told them that I'll address their primary need. What they want is the eye to be central. So we'll modify the plan accordingly and thought we'll proceed with the surgery. This is what we have isolated the medial rectus and the medial rectus is being recessed for about 4 to 5 millimeters so that the esotropia is corrected. In the same eye, the inferior rectus also was isolated, that is hooked, disinserted, and again simple recession of the inferior rectus also in that eye about 4 to 5 millimeter to correct the 18 diopters of hypotropia in that eye. So the left eye had a medial rectus and an inferior rectus recession alone. The right eye, because there was an incommitant deviation and it was more, we had done a superior rectus recession of about 6 millimeter to bring that eye down. So the plan was reduced to that's the superior rectus being recessed and the conjunctiva closed in the right eye in the same sitting both eyes. So we had just done a medial rectus recession and an inferior rectus recession in the left eye and a superior rectus recession in the right eye, so that hoping that the eye will be central. So this was the postoperative look. He was fixing with both eyes centrally, and even when the other eye is fixing, there is no hypertrophy of the right eye, and this is the first time I saw him smile. And elevation is also a little improved because the inferior rectus traction which pulls the eye down has been recessed. The versions are full, and you can see the down gaze is also sufficiently cosmetically better. There's a lid crease prominent showing that the levator is not so fibrotic and the ptosis is not of a true element, and the levator function is full. And the Marcus gun is a minimal, but it's not so prominent, and we told them that this is not a movement which you're going to do in everyday life in front of everyone. So that has made him happy, and his parents were also satisfied with the result. Thank you for the question.